So, dear Chairman, ladies and gentlemen, once again, let me thank the organizers and especially Dr. Spargias for their kind invitation. So the case I would like to present to you is about a 79-year-old male patient who was recently admitted in our hospital because of signs and symptoms of uncompensated heart failure due to severe aortic valve stenosis and the paroxysmal atrial fibrillation, which was successfully converted to sinus rhythm with a DC shock after a transesophageal echo. He is an obese patient with a body mass index of 35 and has a previous medical history of rheumatic heart disease, as he underwent surgical mitral valve replacement with a bioprosthesis, a Hancock 29 millimeters bioprosthetic valve. At the same session, he had a tricuspid valve annuloplasty and CABG with 2 grafts, a Lima to the LAD and a vein graft to the RCA in 2013. He has also a chronic impairment of his renal function and depression, as well as hypertension, hyperlipidemia. Here is medication with the NOAC because of the paroxysmal atrial fibrillation and the high CHADS2 vascor, and some other medicines to control the rhythm and the rate of the atrial fibrillation. His Euroscore 2 was 9.15. The STS was also very high for both morbidity and mortality, so it's a high-risk patient for reduced surgery. And we had a heart team discussion about this patient, and we all decided to proceed with transcatheter aortic valve implantation. I don't know if Mr. Chairman would like to discuss.
I think it's a clear indication. I don't know if any of the surgeons. Dr. Riardon, do you have any comment on that? Yeah.
So it's a patient with a previous sternotomy and a patent Lima just beyond the sternum. So I think it.
Yeah. I think it's definitely an indication for TAVI, yes.
So this is the baseline ECG with a narrow QRS complexes and a PR interval at the upper normal range. And this is the transthoracic echo, which confirmed the diagnosis of severe aortic valve stenosis with extreme calcification of all 3 leaflets, good contractility of the left ventricle, which was confirmed with global longitudinal strain, well-functioning mitral bioprosthesis, and the mean gradient of aortic valve of 42 and the peak gradient of 70. And this is the coronary angiography and the control of grafts that was performed a few weeks before the TAVI procedure. Total occlusion, chronic occlusion of the right coronary artery, some diffuse disease of the left system with occlusion of the LAD ostially. And this is the Lima that was patent, supplying well the moderate-sized native vessel. And the right side video is the vein graft to the right coronary artery, which is a good graft, widely patent, supplying well the good-sized right posterior descending artery. Here is the ECG-gated multi-slice CT, which showed the extreme calcification at the tips of the 3-leaflet aortic valve, confirmed once again the patency of the grafts, and showed that the distance from the vein graft of the right coronary artery to the aortic annulus was 60 millimeters, 60.5. Interestingly, the distance from the aortic valve to the mitral, the skeleton of the mitral bioprosthesis was small, was 2.9 to 3 millimeters. And the virtual placement of the Evolut valve, a 29 millimeter valve, was, as you can appreciate here, it was a borderline position with some risk for to interfere with the leaflets of the bioprosthetic valve. These are the measurements of the CT that were done by our hospital with a 3-Menzio. The perimeter was 76.9. The minimal diameter was 21.7, and the maximal diameter 27 millimeters with a mean of 24.3 millimeters. And this is the ECG-gated multi-slice CT for the peripheral arteries, which showed insignificant disease of iliac and femoral arteries, some calcification at the posterior wall of both common femoral arteries that must be taken into account during the ultrasound-guided sheath placement in the femoral arteries.
So, George, if I may interrupt you. So, historically, we know that when we're dealing with a TAVI procedure involving a mitral prosthesis as well. So, we want to have, when we deal with self-expanding valves, a distance of mitral to aortic annulus maybe around 4, at least 4. So, here we will have less than 3. So, are you worried at all to
Yes.
use a self-expanding valve? Would you consider a balloon expandable valve? And I didn't see any mitral angulation measurement. So, do you think it's a factor on that?
The angulation was favorable for TAVI procedure, was not so unfavorable for that procedure, and the distance was truly small. That's why we considered that the implantation of a self-expanding valve that can be repositioned, resheathed, and repositioned will be a good idea in this case. And we wanted a very stable platform, a stable system that will offer this stability in order to have good chances to anchor the valve in the correct position. Obviously, it was a small distance with high risk of embolization of the valve, but sometimes it was also mentioned yesterday, this distance is not so, sometimes not so critical, because even by protruding within the mitral bioprosthesis by 1 or 2 millimeters, it doesn't interfere with the function of the bioprosthetic leaflets. So the mitral valve is still functioning, even if this protrusion within the mitral valve system is a minimal of 1 or 2 millimeters.
So would your practice change if this was a mechanical valve, or if it is, or even more if it's a single leaflet valve? And maybe this question can be answered by Dr. Riardon as well.
Yeah. We talk about this every time we do a TAVR with a previous mitral. I've never seen it interfere. With a balloon, I'd be very worried with this biologic valve and blowing up your balloon with those struts there. Now, if it's a mechanical valve, that would, we think about it. I've never heard a balloon with a mechanical valve with a balloon. But in this valve, I think this will work fine. There's always more distance than you think on the CT. And we've yet to impair a mitral valve by putting in either an Evolut or a balloon expandable valve. But again, with the biologic valve, you have to worry about pulling up your balloon to expand your valve and bending one of the posts.
Okay, so there's no issue. Any other comment from the audience? Any other surgeon? Dr. Dimitrakakis, you have a question on that? No? It's fine, okay.
So we decided to use the new device from a Medtronic platform, the Evolut FX system, with multiple new features that improve the quality of this device. It has a redesigned tip that makes the sheath, the tip looking and functioning as like a dilator with a very smooth insertion without causing any damage to the femoral artery. Redesigned capsule which increases the flexibility of the system. A single spine shaft for greater shaft flexibility and improved deliverability. A stability layer that improves significantly the stabilization of the whole system in order to decrease the possibility of protruding within the left ventricle, which something is happening with the balloon, with the self-expanding valve of the Medtronic platform, and enhanced visualization by using the 3 gold markers that are placed at the level 3 millimeters above the distal tip of the valve, and they're very helpful in order to identify the annulus and the correct position at the annulus. And this is the benefit from the single spine shaft that makes this whole system to deliver it more easily and to move around all the directions compared to the previous generation that moves only in 2 directions. And here is the stability layer, this green layer, which improves significantly the stability of the whole system. So it prevents this movement. You can see in this territory here from the Evolut Pro system, which sometimes protrudes in the left ventricle. Even if we pace the patients in high heart rate, this sometimes it's unavoidable, and to have some deep protrusion within the left ventricle, increasing significantly the risk of permanent pacemaker need. So this is the TAVI procedure that was done through the right femoral artery. The right femoral artery, common femoral artery, was punctured under ultrasound. Here you can see the coplanar and the cusp overlap views. And you can appreciate that at least moderate aortic regurgitation. That's why we decided to avoid pre-dilatation of this valve in order to decrease the possibility of increasing the aortic regurgitation. In this particular case, the commisural alignment was not so important because the patient has two grafts, lima to the LAD and vein graft to the right coronary artery, but this FX valve can be easily orientated in order to avoid any problems with coronary obstruction, and at the same time to have easy access to the coronaries post-TAVI. And here is the deployment of the valve using the 3 markers, slow deployment with a pacing of 110 beats per minute. The final position was not bad. We had some moderate, at least moderate paravalvular leak. That's why we decided to post-dilate. We post-dilated initially with a 24 millimeter valve, which was the mean diameter of the annulus. The result was still not good enough. That's why we post-dilated even with a 25 millimeter balloon, and the final result was better. So we left the cath lab with mild paravalvular leak, which was confirmed by the echocardiogram, the transthoracic echo that was done in the cath lab. All our patients are treated with conscious sedation without transesophageal echo over the last 6 or 7 years. And how we used to close the femoral artery, we replaced the 6 French sheath. We use only a single proglide. We put the 6 French sheath back to give some contrast. If there is no massive bleeding, then we use one angioseal, and we finish with this one angioseal, the closure of the femoral artery. This is our practice for 1.5 years, and recently we have some data supporting this strategy, the multi-close vascular closure algorithm, which shows very low rates of major complications in the femoral arteries, which is similar with our results with a complication rate of 2%. The ECG post-TAVI, obviously there was a wide QRS complex and an increase of the PR interval in both 24 hours and 48 hours later. That's why we decided to follow this algorithm, which proposed to proceed with an invasive electrophysiology study. An EP study was done. The duration of the HV delay was 54 milliseconds. So it was a case with very low risk for complete AV block. And according to the guidelines, we worry about this if it's the HV delay is more than 70 milliseconds. That's why the patient left the hospital at day 3 after the intervention without any complications. This is the transthoracic echo post-TAVI, minimal paravalvular leak. We know that the nitinol of the self-expanding Medtronic valve is still expanding within hours after the intervention. And so minimal paravalvular leak, well-functioning mitral bioprocesses. The mean gradient of the aortic valve was 6 and the maximum gradient was 11. And this is our case.
So thank you, George. This is an excellent case. So we don't have any experience with this new valve. Is there a caveat in that? Of course, you have more stability, as you said. You have enhanced visibility regarding the markers. Maybe the nose cone, it's better to to get it in the ventricle, maybe it's better to get it out because some of the pop out that we see, it's due to the nose cone, right?
Mm-hmm.
So is there any caveat in this valve? Would you have a tip on that?
I think we have a small experience with this valve. We used only 4 valves, 4 FX valves. But obviously, we feel that the deliverability and the stability of the whole system is much better than the previous generation. So it's, for example, this case was done for the first attempt. We do now need to take it back or to have any migration towards the aorta. And the same was true for the other 3 cases. So we feel that the stability of the whole system is improved significantly by this new platform. Otherwise, we need more cases in order to have a more wide opinion of if these have some other benefits by using this valve.
This is excellent, and I noticed also it's very important what you suggested, your practice, that you did a electrophysiology study to investigate if there is you measure an HV to investigate if there is a high grade of pacemaker implantation. I don't know if the other centers are doing that. Dr. Riordan, are you doing that?
All of ours are FXs now. That's what we're doing every week. And one thing I have to teach new sites is you're doing the Evolut Pro or the Pro Plus, you're worried about it diving, so everybody starts tie and they hang onto the valve. With this valve, I have to teach the fellows, put it where you want it, let go of it. And if it moves, you have tension in the system. Once you can get it where you want and let go of it, it's not going to move. You don't need to push or pull. And the other thing is, I'm going to fly back tomorrow. Monday, I'm going to do my first 2 FX Pluses, which is the FX with the 20 French holes in it. So I'm going to fly home, do those on Monday morning, and fly to Paris Monday afternoon. But I think that and commissure alignment will really help in future orientation of access to corneas. This guy's not going to need it, but some of them will.
So that's a very important thing. So we look forward to place this valve. So, Michali, let me ask you. So, do you follow this practice that you talk to your electrophysiologist? So, if you have a new LBBB and an enlarged PR, you ask for an EPS study to measure an HV.
I know people have advocated for that to measure H2V ratios and do EP studies, but we don't routinely do EP studies in our patients. We follow them clinically for the most part.
Okay. We don't do it. Okay, thank you. We have to leave it there. Then we have to go.